Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, Dr. Paul Nelson Williams. Hey, Paul.
Hey, Matt, I feel like your heart wasn't in that one. How are you?
I'm doing okay. Paul, are you familiar with prediabetes?
I've run across it once or twice in my career. Yeah.
Until we did this episode, I guess I didn't really think about how vague the term is because it's kind of an umbrella term and it doesn't exactly tell you how we got to the diagnosis because I think most people are probably getting diagnosed by an A1C. And depending on what source you read, most sources say A1C of 5.7% up to 6.4% is prediabetes and 6.5 or higher is diabetes. But there's actually cutoffs for impaired fasting glucose, which is a fasting glucose greater than or equal to 100, or for impaired glucose tolerance, which is a postprandial, usually like a 2-hour postprandial glucose or oral glucose tolerance test of 140 to 199. So, 2 hours after you take this 75-gram glucose load, you take blood, and if it's 140 to 199, that's impaired glucose tolerance, and if it's 200 or above, that would be considered diabetes. So I hadn't made those the distinctions there, Paul. I'm not sure about you.
No, and actually, I think I probably in the past I'd used prediabetes, impaired glucose tolerance, even impaired fasting glucose probably a little bit interchangeably, as opposed to sort of making the
Yep.
distinction between the two and recognizing that one had sort of more prognostic significance than some of the others. So this was really helpful to kind of help clarify both diagnostically and then also the implications of those different terms.
Yeah. And for a while, I was really not getting fasting labs on people, but I've started to get fasting labs again because I do think it gives you, like, if someone's A1C is elevated and their fasting glucose is elevated, I'm a little more worried about that person. But actually, Dr. Isaacs was telling us, and this is what the literature would say, is that the impaired glucose tolerance, if you can get that value, which I think nowadays it's a little easier to get, you could have someone do a 2-hour postprandial finger stick or and get a couple of those readings and see if it's above 140. But that actually it predicts worse outcomes, higher risk for diabetes if people have that impaired glucose tolerance. So I do think it's worth checking for these things and making the distinction. And if maybe the patient has a normal A1C, but they have impaired glucose tolerance or impaired fasting glucose, you might pick it up. You kind of improve your sensitivity by testing all three.
Yeah, and that also touches another point that Dr. Isaacs made in terms of discussing this with patients and why they should care. Because again, I think prediabetes is often framed as in, well, your sugars are a little bit higher than normal, but you're not quite at diabetes yet. And I think that's extraordinarily abstract. And I'm not sure, the way patients respond to it's going to be kind of variable. And he actually talks about it more in sort of a complications based discussion with patients. Here are the things that we worry about with diabetes and the things that we're trying to prevent from happening. So he actually talks about his goals with prediabetes, specifically one of which is preventing progression to diabetes, and then also preventing the downstream complications, which include things like fatty liver, which is or steatotic liver disease, I suppose is the better term these days, which is just as prevalent as type 2 diabetes, cardiovascular disease, chronic kidney disease, HFpEF, sort of all the things that ride along with this. And so by trying to um, mitigate the progression of prediabetes, you're also helping prevent some of these other chronic diseases, which can be obviously devastating as they progress.
As a brief aside, Paul, I'm kind of fighting against the term steatotic liver disease because it's fatty liver. It just says what it is. Patients understand it, but I understand for coding and for communicating with other clinicians, we can use that. But I just tell patients it's fatty liver. Like
It's pretty
it's
evocative. Yeah, you can't argue that.
yeah, yeah. Well, Paul, we also talked about that not all cases of prediabetes are this classic insulin resistance type 2 pre-type 2 diabetes. So we talked about, and I thought this was really interesting, atypical prediabetes, and there's a bunch of them that we talked about. So there's pre-type 1 diabetes, there's pancreatic prediabetes, there can be people who have Cushing's or this autonomous cortisol secretion, and then there's acromegaly. So, Paul, uh, tell us, how would we make the diagnosis of pre-type 1 diabetes? Because I wouldn't have thought that's possible.
Yeah, I love this recognition that all illness starts somewhere, including type 1 diabetes. So it's type 1 diabetes, just as a reminder, is thought to be an autoimmune condition. So if you see someone with these sort of prediabetes type labs and someone who has other autoimmune disease, so if they're presenting to you and they've had a history of vitiligo or Hashimoto's or rheumatoid arthritis or even inflammatory bowel disease, especially at a younger age or with strong family history, that might prompt you to start doing the testing for this pre-type 1 diabetes, which, as a reminder, you can diagnose type 1 diabetes anywhere in life. It does not have to be the
Yep.
childhood diabetes I think that we've been classically taught, or at least used to be classically taught in medical school. And so to work that up, you'd be sending the antibodies. There's the GAD65, which I feel like most folks know about, which I learned can go away as the disease progresses. But there's also the insulin autoantibodies, the insulinoma associated protein 2 autoantibody, which is fun to say, and the zinc transporter 8 autoantibody. And there's usually order sets. There's other ones, and you can order these usually as part of a panel with the big commercial labs.
Yeah.
And the more positive, the more that are positive, the more likely are you're dealing with like a type 1 diabetes or about to be type 1 diabetes than one of the other flavors of prediabetes.
Yeah, and we're not going to go through all of them, but just briefly, if people have a history of pancreatitis, you can think about this pancreatic prediabetes, and that's important to note because if someone has diabetes that's related to damage to the pancreas, they might need insulin sooner than later. But Paul, speaking of treatment, is I know lifestyle is going to be, lifestyle, everyone knows that lifestyle beat metformin in the diabetes prevention program, but what about pioglitazone, Paul? Is that one something we might think about?
Our guest is a big fan of it, and I've been thinking about it more and more. So I'm trying to think of ways to sort of thoughtfully incorporate it. I think the point that our guest made is that the side effects that we worry about, the fluid retention specifically, happen at the higher doses, and the recommended dose for prediabetes would actually be this 15 milligram dose of pioglitazone, which actually has really good evidence to support it and seems to work really, really well. So this whole conversation did prompt me to rethink pioglitazone, which I feel like was just sort of thought about categorically as a bad guy at one point, and now seems to have some utility in certain cardiometabolic processes.
Yeah, I mean, it was more effective than metformin, and from the numbers he quoted, it was more comparable to like the exercise lifestyle interventions as well.
Yeah.
So for the patient that doesn't have like heart failure or already have problems with edema or osteoporosis, it might be something that you think about. So, very great episode. I mean, I would encourage people to listen to the whole thing because we really got in depth on it, and there's so many great pearls, more than we could recap here. So, Paul, I will say, with all that, I've been Dr. Matthew Frank Watto, and this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
And Matt, no one says that better than you. And I remain Dr. Paul Nelson Williams. Thank you and goodbye.